Welcome to Focus on Health, a series of educational programs highlighting current health issues sponsored by the Department of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Professor of Nursing at Salisbury University and host of the program. I welcome to the program Dr. Mark Edney from Peninsula Urology. You are a urologist. And then I also welcome Casey Duld. You are a certified genetic counselor and you work for NxGen, MD.
That's right.
I think it's important to say that you informed me that you're the only certified genetic counselor on the Eastern Shore, and obviously an expert on the topic of this program, along with you, Mark, on genetic risk and cancer. So let's start with Mark in terms of discussing the different types of genetic risk with some examples, including prostate cancer, which of course you do a lot of treatment of.
Yeah, absolutely. Thank you for having us to do this show, because I think it's a really important topic, and I think it's the subject of a lot of confusion in the community, this whole idea of genetic risk and just how much risk is a lot of risk, and how do you test for risk, and how do you know? And so we're going to explore some of those issues. The genesis for this really is in prostate cancer and urology, and my specialty. We're coming just over the past few years to really understand a whole new element of genetic risk in prostate cancer. And so I'm going to use prostate cancer as a jumping off point, but we're then going to sort of discuss cancer risk in general and genetic testing and some of the strengths of genetic testing, the promise of genetic testing, but also some of the risks involved, because there actually are some real risks that people need to think about in genetic testing.
Can I ask, is prostate fairly new on the horizon with this genetic piece? Because we've all heard about colon cancer and breast cancer and such, and so is this kind of a newer area of exploration?
In fact, it is. It's much newer. Breast cancer is so much further ahead in terms of genetic research. People have known about, for example, the BRCA1 and 2 genes for a long time now, and those tests are very well established in terms of hereditary risk of breast cancers. And we're just starting to understand that, in fact, that very same gene, BRCA1 and BRCA2, confer risk of prostate cancer for men who have family histories that contain BRCA genes. And so one of the important takeaways is prostate cancer is the most common kind of cancer that men will be diagnosed with age, just like breast cancer is the most common kind of cancer that women will be diagnosed with. So it's very common. There's a lot of it out there. And one of the messages that I want to put out there is that in terms of assessing any man's risk of prostate cancer, family history is increasingly becoming very, very important. And so if any man has a family history of breast or ovarian cancer, they should consider genetic testing for the BRCA gene, because if that runs in their families, it confers extra risk on them for developing prostate cancer. And if they develop cancer, sometimes it's more aggressive. And so starting to take these family histories and understanding for everybody in the community, understanding the important elements of your family history of cancer, and Casey's going to talk a little bit more about that in a few minutes, but understanding what's important about your family history and making sure that you confer that information to your physician. And quite honestly, different specialties of physicians have different comfort levels with handling that family history information. I'll be honest, in urology, I learned how to take a good family history in my training, in my surgical training, but until recently, the impact of family history on my clinical decision making, quite honestly, wasn't very high. That's changing, and so I'm now having to retrain myself, and I'm starting to sort of talk to my colleagues about the importance that we really need to get back to family history and start taking family histories and understanding them, because there's a lot of genes out in the community that confer risk for my patients, my potential prostate cancer patients, that we previously didn't know about, but we do know about them, and we need to find these genes. An interesting statistic is that for BRCA2 genes, families, we are only aware of about 15% of all the BRCA2 that exists in the country. So there's a whole lot of BRCA2 and 1 genes out there in the community that we don't even know about. And we're only going to get to them if we start taking really good family histories and considering the appropriate genetic testing for people who have the positive family histories. We're then going to start to find it. And finding those genes has a lot of potential upside. And again, that's something sort of Casey can talk about. There's a lot of information you get with genetic testing, and we have to talk about those nuances. But you can talk about your family member's personal risk of developing cancer based on these genetic tests. You can talk about, if you've been diagnosed with a cancer, how likely is that cancer to behave over time, and how might it need to be treated? But also an additional family of information, if you will, that comes from this genetic testing is what's the risk to my family members? You know, I've got kids, or maybe I have grandkids. You know, are they at risk based on things that we know now about my family history? And so all of this information is possible to uncover, but it should be done very carefully, and it should be done with the counsel of a genetic counselor who's trained to go into all of these nuances.
Now, I know you wanted to talk about the 3 different types of cancer risk without getting too technical, because
Right.
this is quite complex.
So
but
it is, and I'll try not to get too terribly technical, and Casey can sort of help me where I may be not being as exact as I can be. But we tend to think of cancer running in families as one big sort of thing. One, you know, there's cancer in my family, and our notion of personal risk based on cancer being in the family tends to be sort of this monolithic thing. It's either there or it's not. When in fact, there are actually a couple different important categories of family risk of any kind of cancer. There's sporadic cancers. These are the cancers that just pop up, okay? There wasn't any prediction based on your family history that you may have been at risk for something, but you were just unlucky enough to have the change in your genes to cause a cancer. That's called sporadic cancer. There's familial cancer, and these are cancers that in fact can run in families, okay? You can have a father, in prostate cancer, for example, a father or brother who had prostate cancer that may affect your personal risk of developing cancer slightly. That familial cancer, the difference here is that it's probably a variety of different genes, and we don't have an idea of any one specific gene that's operative in familial cancer. We just know that if it's in your family, you may be at slightly higher risk of developing it. The third bucket is hereditary cancer. Okay, and again, these terms are very similar and they're very confusing.
yeah, I mean, I thought they were interchangeable myself.
The important thing about hereditary cancer is these are the cancers for which we have identified the gene that causes the problems. And the example here is the BRCA2 gene. So if you have BRCA2 in your family, okay, you have a hereditary cancer risk. Both for the women, it's breast and ovarian, and for the men, it's prostate cancer. And so that genetic testing is important to know if you have that specific gene which confers on you and all of your progeny extra cancer risk. And so different buckets, and the risk is multiple times higher than that familial cancer risk. If I have a father or brother who developed prostate cancer, my risk might be one or two times. But if I have a hereditary gene in my family that are in all of my cells, that the presence of that gene can confer risk sometimes upwards of 8 times, 10 times, 15 times. So we're talking about different magnitudes of risk, and really that's the main point I want to convey, is that not all cancer that runs in families confers the same risk. And it's the hereditary cancer testing that we'll spend a lot of time, in the genetic testing that we're going to spend a lot more time during this program talking about.
And is there any relationship to the severity of the cancer, or the aggressiveness of it?
Absolutely, yeah, and lots of different cancers, including prostate cancer. So a BRCA2 positive prostate cancer, we know, behaves clinically much more aggressively, has much more propensity over time to spread, metastasizes to different parts of the body at a higher rate. So absolutely it can affect the aggressiveness of the cancer.
So I know with prostate cancer, we hear of cases in men that their prostate cancer may outlive them. The watchful waiting approach, if it's slow growing, and
Exactly
then there's
right.
others that are more aggressive.
That's
so you're
right.
saying if you have the more watchful waiting variety, then that probably isn't as genetically related,
Well,
or it can be.
So that sort of gets into the question of who are the best candidates for watchful waiting.
Okay.
And so we base most of the time that decision on the information we get from a biopsy, which is called a Gleason grade, which is the aggressiveness of the prostate cancer, and the PSA and a man's age and other health factors. Those are the things that traditionally we have based our decision for watchful waiting on. And I tell you, the majority of the time, that's plenty of information to make that decision. However, to your point, if I have a man with all of the clinical characteristics of a person who would be good for watchful waiting, but he tells me, oh, by the way, my mom died of ovarian cancer, I'm going to think about getting the genetic testing done to make sure that this man doesn't have the BRCA2 gene, because if I find that he does, even though he's got all of these other factors that wouldn't necessarily put him at risk, having the BRCA2 gene puts him at risk for a more aggressive type of prostate cancer. That's a man I'm likely not to observe. I'm going to treat him because he's at risk for a much more aggressive form of the disease.
Yeah, I think there's multiple pieces to the puzzle that we have to consider, and we can never just focus on one and forget the others, because we're going to miss things when we do that.
Well, let's move on, I guess, more into the genetic counselor role there, and then we can explore some other issues.
Sure.
Yeah.
Yeah, so a genetic counselor in general, because I'm not sure that everybody exactly knows what a genetic counselor is or what we do. So we have a specialized background in genetics and counseling, and we use those skills to help patients navigate their genetic health history. So we can do that by taking family histories, drawing three generation pedigrees, then interpreting the family history and telling them how certain inheritable conditions might affect them and their family. We can suggest appropriate genetic testing, and then we can help to interpret the genetic results or test results once they get them back. In terms of how that works in the cancer field, family history really becomes an important part. So just knowing that your mom or your aunt had breast cancer or colon cancer isn't necessarily the most helpful information for us. We need a few more details when we can get them. So many times before you even come to see a genetic counselor, patients will get a form in the mail or email asking them all kinds of detailed information about their family history. Questions will include age of diagnosis, types of cancer they had, so even breast cancer isn't specific enough. If they happen to know the exact type of breast cancer they had, that can be helpful as well. If it was unilateral versus bilateral, if it was bilateral, are they both primaries or was one a metastasized cancer of the first? We want to know how many affected relatives there are, if there's rare cancers. And even once we find that information, we may then go look at medical records. We may find histology reports of tumors and things like that. So a lot of information is needed to determine if a person is a candidate for genetic testing and then what type of testing is most appropriate.
I know you brought up age of diagnosis. Do these genetic-related cancers tend to occur in younger people, or you get them at a younger age, and that's when the kind of red flag might go up to say,
Yes, early onset cancers is one of the red flags, and it's because people with these inherited mutations are sort of already born with one strike against them in terms of inheriting or developing a cancer. So when you already have that one strike against you, it takes two strikes, so to speak, to develop a cancer. So when you're already down one strike, it doesn't take as long to get that second strike, if that makes sense.
I mean, the same's true with Alzheimer's. I know that's not cancer, but the early onset type is the one that there's a direct link versus just a familial predisposition, which can also exist.
Exactly.
The whole field is so fascinating. And I know our audience has probably heard a lot about the breast ovarian cancer issue, but you're saying with men, this is a newer development. So let's talk more.
Yeah, absolutely. So that's one of the take-home messages is that family history is critical. Whether it's breast or ovarian, but if you have a family in which there's breast and ovarian cancer, the men really need to sort of consider. Everyone needs to consider testing, but the concern for the men might be prostate cancer. And so to sort of talk a little bit more about sort of genetic testing and sort of how do you go about that? You've heard this show and you say, boy, I've got a lot of cancer in my family history. Do I qualify for any type of genetic test, and if so, what? And that's really, again, the role of what Casey does is helps go through which are the cancers, where are they, and based on that pattern and that history, which genes is Casey sort of concerned about, and then the genetic counselor goes through and orders specific panels of genes based on your history to inform what you might be at risk for. But not all laboratories are the same, and this is an important point. Especially with the advent now of the internet and companies sort of making sort of proprietary products that are direct to consumer vended, bypassing medical professionals and genetic counselors. Things like 23andMe have a lot of potential downside, and so I think Casey's going to talk a little bit about sort of the elements of what go into sort of a good, reliable genetic test, and what are the potential downsides of things like 23andMe.
So using a trusted lab and medical professional guidance versus do-it-yourself type thing,
Absolutely.
Ordering it online.
Right, yeah, you want to make sure that you're using a good certified diagnostic laboratory if you're going to do these types of medical tests. Now, in terms of the direct-to-consumer tests, people are still going to do them. We can't get away from them. So they're going to get this information. So companies that you might want to look for are companies that have genetic counselors on staff. So I know 23andMe has genetic counselors. That's the plus side. The downside is that you only get access to the genetic counselor if you call. So these consumers who are getting the test and having the test results, let's say that they get a negative test result for the BRCA1 and 2 genes, and they say, oh great, so I'm not at risk for breast or ovarian cancer. Well, that's not quite the whole story. So I always would encourage somebody who has these tests to make that phone call and call the genetic counselor just to go over the results to make sure that they have a complete understanding. For patients who get a positive result, of course that's information you want to take to your doctor. And at that point, the doctor may say, okay, that's great. Let's send this, we're going to have to test you again. We want to send you to a certified lab so that we can verify that this result is true. It also can affect insurance. So sometimes...
That's what I was just going to ask you. You mentioned the word qualify. I'm like, does insurance pay for genetic testing? I guess not for the 23andMe, but if it's ordered by a physician?
In the certified labs, most of them do, and it takes a while. The whole payment piece is challenging because a lot of the payers require a lot of data to show that, yes, this is a robust test and you have lots of pieces in place in order to pay for it. But in the larger sort of national companies with lots of experience, like the one Casey works for, their panels most of the time are paid for because they have all kinds of experience and they've shown that they actually have a robust database and that their results are accurate and they have the appropriate amount of follow-up. But it's an important point I wanted to make about the genetic test is that a genetic test is not positive or negative like we think of, for example, a pregnancy test, where you get a test and either it's positive or negative. It's not a yes or no situation. When we get a panel of genetic tests, you're testing for a panel of genes and you get back oftentimes a report on different variants of different genes that are present. The question is, are those variants clinically significant? And that's the whole rub with genetic testing. And the answer to that question can depend on the quality of your laboratory. And so if you have a laboratory that is constantly monitored and with clinical follow-up of all of the people in that database, because these huge databases develop with all these genes in them, with the known clinical outcomes of the genes, you need an actively monitored database to actually really with accuracy say, yes, the variants we detected in you are clinically significant and confer either risk of future development of cancer or risk to your family. And so that active monitoring piece is important. And sometimes a result will come back that says variant, what's it they call VUS, variant of unknown significance, meaning we found a variant, for example, BRCA2, a variant that you have, we're not sure of its clinical significance. We're not sure it's nothing, but we're not sure that it poses you great risk. This needs to be followed over time, and the best laboratories will follow that over time. And if in a couple of years down the road it turns out that particular variant turns out to look like it's causing significant risk, they'll reissue a report. So you can get a report 2 years later saying, the thing we thought 2 years ago that wasn't causing a problem, looks like now it may be causing a problem. You may want to reconsider either getting screened for various types of cancers or a variety of different prophylactic maneuvers that you can consider if you're at very high risk for certain types of cancers.
Now, if you're seeing a patient who you think genetic testing is recommended, do you also go back and test family members that are still alive? I know oftentimes we're taking histories and the people have passed away, so all we have is a verbal report that they had this kind of cancer, and we may not even know that if the person doesn't have that information.
Absolutely. I'll let Casey address that. That gets into the nuances, the ethical nuances of testing and the conversations you need to have with patients.
And even going back to who the most appropriate person to test is in a family. So someone might come to you and say, I have this family history of cancer, and I want to do this testing, but that person has never had cancer themselves. So let's say they do the testing and they get a negative result. In those cases, it's not exactly a true negative because perhaps, if their mom had breast cancer, perhaps she does have a BRCA1 mutation, but the patient didn't inherit it from her. So while yes, that patient is negative, it doesn't mean that gene's not in her family. So it doesn't give us the full story. The best people to test in the family are the people who have cancer. Right. So oftentimes in genetic counseling sessions, if somebody were to come to us in that situation and there was time to do so, we'd say, well, is your mother interested in any of this? She would be the most informative person to test. So that's step one. And then if the patient says, no, she's not available to test, she doesn't want to do this, then you've got this patient sitting there and you do her testing and you have to kind of talk about what this information is going to mean to her family. So perhaps her mother doesn't want the testing because she doesn't want to know. Perhaps she would feel too much guilt if she knew she passed these gene mutations onto her children. But the patient still wants the testing, and then let's say she's positive, and then let's say she wants to do prophylactic mastectomy. Well, then her mom may see her going through all of this, and her mom's going to say, oh, wait a minute, that must mean she has this gene mutation that I probably gave her. So even without actually telling the mother that she had the mutation, mom can kind of figure it out. So these are all types of things that we discuss with patients when they're considering having these tests, because a genetic test result will affect more than just the patient.
Oh, absolutely. And there's significant implications. I know you wanted to chat about that. You mentioned one, a woman that might go ahead and get a prophylactic mastectomy or double mastectomy, or so let's talk about that. What do you do with that information?
Yeah. So my best advice from a physician perspective is if anyone's considering hereditary cancer testing, or certainly if we now have the ability as urologists to order these panels of genes. And so if I detect a family history in the office, I can actually go ahead and talk to the patient about it and order this panel of genetic tests, and the genetic counselors probably cringed because we may not always handle that situation or order the appropriate tests, quite frankly, but we have tests that we can order that have been proven to sort of correlate with these family histories. But then, what do you do with that information? I certainly am not trained to go through all the nuances that Casey just described with respect to what does this mean for you, what does this mean for your members of your family, and all the ethical issues concerned. So the first thing I would do would be to get that patient connected with a genetic counselor who really is trained to go through these issues.
And we have, as a genetic counseling community, I think when all of this cancer knowledge first came out, we kind of wanted to be the gatekeepers because we know all of these nuances, but there's just not enough genetic counselors to go around. We can't see every patient that has a family history of cancer and offer them all this testing and things like that. So we need well-informed physicians like Mark so that they can do these things and then make the appropriate referrals.
And
so we don't cringe.
Where do most genetic counselors work? I mean, you work for a company. Will there come a time, you think, where we'll have physician practices in these areas where there's a strong genetic link, where genetic counselors will be part of the team, or how do you think that's going to be working?
So currently, I'd say you find genetic counselors closer to the larger cities. You aren't going to find them in the rural areas. I am still here because I'm from here and I grew up here, so I've stayed here. A lot of the labs, however, so just like what I do, genetic testing labs are hiring genetic counselors, and then physicians are utilizing the genetic counselors that work for the labs.
Okay.
So I counsel patients over the phone who get positive test results with my company that may not have access to a genetic counselor who the doctor says, I don't understand everything about this result, please talk to the company's genetic counselor. So I think we may see more of that to get the resources out to everyone that might need them.
The other thing I was wondering about is Mark, do you foresee, I would assume it's happening now, are medical schools really emphasizing this piece of genetics and all the various disease processes?
Yeah, so the basic science that's taught in medical schools is changing all the time, and the medical schools are very good at staying sort of up to speed. And so, the cancer that's being taught now in medical school is very different than the cancer that I was taught as a medical student 20 years, some odd years ago, because the science does change, and it changes rapidly. And so, yeah, I think that the medical schools are keeping up with the latest science, and as we go through residency programs and we're training clinical physicians in their specialties, I think there are some specialties that probably spend a lot more time on it. Obviously medical oncology now and the whole field of cancer is important, and gynecology, general surgery that deals with breast cancer has been doing this stuff for a long time. Urology is just sort of, as I was saying before, just starting to get into this space because the science has really, only in the last couple of years, started to evolve to tell us that we as urologists actually need to be aware of this stuff because it could really impact our patients. And we just didn't have that information before. And so it is for the training programs and the urology residency programs to stay abreast of the latest sort of developments in genetic risk and to be able to really re-emphasize the taking of family histories in the urology clinic. Even though we're seeing men and talking about prostate cancer screening, it's important to take that family history of breast and ovarian and pancreatic can be involved in colon cancer. There's another syndrome called Lynch syndrome, in which prostate cancer is involved, but Lynch syndrome is a much higher risk of colon cancer. And so if we're seeing sort of strong family histories of colon and pancreatic or a couple other types of cancers, the question should go off in the back of our minds, might this be a Lynch syndrome family? In urology, not only prostate cancer, but cancer that involves the lining of the ureter and the kidney. It's called transitional cell carcinoma. It's not a common type of cancer, but when it's present, there's a risk for having this Lynch syndrome family of genes, which again are that hereditary line. There are several identified genes that confer increased risk. And the risk happens to be in colon cancer and endometrial cancer. But if I have a patient in my urology office that has a history of this urothelial transitional cell cancer, I need to start thinking about Lynch syndrome and start taking family histories, and if they're positive, consider or at least offering genetic hereditary genomic testing to see if it's there. Because again, the implications, not only for you personally as a patient, but for your family, are significant. And so, you know, it's a newer science, and the education of the providers coming through sometimes, and then the application of this always lags behind, you know, because there's always new science, and then it's many years down the road before this really becomes common practice. And that's just sort of, unfortunately, the human nature of the business we're in. But it's for us to have shows like this and start talking about it, make sure there's public awareness, and so that even if your particular provider hasn't necessarily seen sort of the latest stuff, that doesn't make them a bad provider. You can't digest all of the information that's out there. But if you prompt them and say, hey, by the way, you know, I saw this show and I've noticed this in my family history. Is that important to what we're dealing with here? Patients need to be activated to really start asking these questions. Because,
right, you mentioned that earlier, and that's what made me think, because I think there's a subset of patients that wouldn't think to ask.
Yes, that's right.
And to me, it's incumbent on the physicians, you know, to bring it up and to ask those questions and put those kind of questions on intake forms and so forth. So hopefully everyone's more informed and get the word out about how important this all is. I know we wanted to chat just a little bit about, you know, the implications not only in the treatment options, but, you know, there's an ethical piece to this of, you know, when do you want to know, when do you don't want to know, or I don't know if you want to address that, and the genetic counselor has to be very careful and to not look as if you're helping with a decision. You're just an information giver, correct?
That's right, yeah. So we are there to present the information. So when you go to a cancer genetic counselor, they're going to take that family history and go through it with you. They're going to tell you what their interpretation of it is, and of course suggest any testing that might be available and appropriate to the patient. Then they have to talk about insurance and how much the insurance is going to cover. Whether we like it or not, sometimes the insurance company dictates health care. So they have specific guidelines sometimes you have to meet in terms of family or personal history in order to qualify for testing, or at least they used to. So you take all of that information together and kind of give the patient the picture. And then on top of that, you have to start discussing some of the other factors, the family piece, how it's going to impact your family, family planning. So if you have this mutation and you want to have children, could you pass this on to your children? Life insurance. So the Genetic Information Non-Discriminatory Act, that GINA Act, protects you from being discriminated by health insurance companies based on your genetic information. But if you did this testing and you tested positive for one of these gene mutations, you may not be eligible for any more life insurance, or they're going to charge you an outrageous amount to get it. So those are all things somebody has to consider or should consider before they pursue the testing at all. The test itself is easy. It's a blood test or a cheek swab, and you just send that off to the lab. So that's the easy part. Knowing what you're going to do once you get the result is kind of the hard part.
Right, and I assume the 23andMe, people pay out of pocket for that, obviously.
That's right.
Do it online, and that runs about how much? And then the tests from a reputable lab through a physician. What if it's not covered by insurance? Would people pay for that out of pocket if they wanted to? They could?
The company that I work with in Salt Lake City has a huge, and I'm sure Casey's company as well, has a patient sort of financial office to help people sort of who can't afford, you know, who are candidates for testing, who can't afford it out of pocket. Most of the genetic panels that the company that I work with provides are covered by both Medicare and by private insurances, and they tell patients that in any case they're not going to have to pay very much at all out of pocket. So most companies will work out the financial aspect. These companies, really most of them are in it for taking good care of patients and really for finding these genes and helping families, and they don't want the finances to be a burden. And so I haven't heard of any real problems, the financial problems being a barrier to getting appropriate genetic testing for people who really need it.
Okay, that's good to know,
Yeah.
because that always comes up.
Yeah.
Is insurance going to pay? How much?
Yeah.
And
Yeah.
well, this is quite a complex but exciting topic, and hopefully it'll open up some other opportunities to really fight cancer, properly and so forth. And I appreciate you both coming in. I know you're very busy, and to talk about this topic, I think it's quite informative. Before we sign out, any take-home point you really want to drive home from each of you?
My message to folks in the community is be aware of your family histories of cancers in particular, where this is we're talking about genetics of cancer, and let your providers know, whether it's your family physician or if you're seeing a specialist, if you've been diagnosed with a cancer, really try to dig back in your memory as much as possible. Be aware of your family history, and if it wasn't asked of you, offer it and say, just so you know, I've got this in my family history, and kind of come to the table with that and prompt your care providers to consider that, because we're learning more and more about it over time, and it's a critical element to people's histories that sometimes historically we haven't done a great job at taking, but it's becoming increasingly important that we do that.
Okay, Casey?
I wholeheartedly agree with everything that Mark said, and even more broadly, we're learning more about how genetics impact lots of conditions across all fields. So learning family history and knowing family history, medical history, is just becoming more and more important in healthcare. So just know your family history when possible.
And talk to your physician or provider,
Yes,
I think,
right.
Yes.
is most important, versus just taking matters into your own hands and ordering a test online,
Exactly.
and knowing that a good lab is important.
Yes.
So thank you again for being on the program.
Thank
Right.
you.
Thanks for having us.
And thank you for joining us for this edition of Focus on Health here on PAC 14.